Hepatitis C is an enveloped, positive sense, single-stranded RNA virus. Structurally and genetically, it resembles a flavivirus, and the genome has one long open reading frame. Structural genes at the 5' end and non-structural genes like RNA polymerase at the 3' end. Unlike Hep A and B, hepatitis C has six major genotypes that impact disease severity and treatment response. Genotypes 1 and 4 historically responded poorly to interferon therapy, while 2 and 3 responded better. And we'll discuss later how modern direct-acting antivirals have really changed our outcomes. Looking at the viral structure, hepatitis C has a lipid envelope, which makes it less environmentally stable than Hep A, but also helps it evade the immune system. Inside the envelope, we'll see a nucleocapsid that contains the RNA genome, and hepatitis C's ability to mutate rapidly, especially in the envelope region, contributes to chronic persistence because the immune system struggles to keep up with all the changing antigens. Hepatitis B is primarily a blood-borne virus, and the highest risk routes include transfusions or organ transplants from before universal screening was implemented, injection drug use, hemodialysis, and occupational needle sticks. Sexual and household transmission is possible, but far less efficient than with hepatitis B. Perinatal transmission can occur, especially when the mother has a high viral load. So take away, think blood exposure first with this disease. After exposure, the incubation period averages about 6 to 7 weeks, and only about 30 to 40% of symptomatic patients will develop jaundice, which is why most cases go unrecognized, and that's why we screen for Hep C. What makes Hep C distinct is the high rate of persistent infection. 85 to 100% remain viremic, and about 70% develop chronic hepatitis. Unlike Hep A and B, Hep C does not produce a protective immune response, and patients do not develop lifelong immunity, and reinfection is even possible. The long-term outcomes of chronic Hep C mirror those of chronic Hep B, chronic active hepatitis, cirrhosis, and hepatocellular carcinoma. One main difference is that the progression in Hep C is typically slower but more persistent. Hep B chronicity is highly dependent on age of infection, but over decades, the chronic inflammation and fibrosis in Hep C damage the liver, ultimately raising the risk of hepatocellular carcinoma even without cirrhosis, but the risk is higher in cirrhotic patients. So this flow diagram highlights what happens following infection. Out of 100 people exposed, approximately 85% become chronic disease carriers and about 15% clear the virus. From those with chronic infection, about 17% or 17 progress to cirrhosis, and a smaller subset develop hepatocellular carcinoma. Unlike hepatitis B, spontaneous clearance is really uncommon, and again, there's no immunity. After clearance or treatments, you can get reinfected. After infection, we'll see our ALT will rise up as liver injury begins. Our hepatitis C RNA appears first and is the earlier marker of infection. Weeks later, anti-HCV antibody will become detectable. However, this can lag up to 10 weeks. It's important to note that antibody positivity only tells us that the person has been exposed. It does not distinguish active from resolved infection. Viral RNA testing is required to determine active infection. So we begin screening with hepatitis C virus antibody testing. However, antibodies alone cannot differentiate a cleared infection from a chronic infection. So to confirm an active infection, we use HCV RNA testing, either quantitative or qualitative PCR. HCV antigen can also be tested and functions similarly to RNA testing, but it is easier to perform. So the key clinical part is antibody means exposure, but RNA plus or antigen equals active infection. So this is kind of our diagnostic algorithm. We start with our HCV antibody screening first. If it's positive, then we're going to follow up with RNA testing, either qualitative or quantitative. If RNA is detected, we perform genotype testing because the genotype historically can guide the choice and duration of therapy. Today, with direct-acting antivirals, genotype still influences our regimen selection, but it does matter less than it did in our interferon era. There are some prognostic markers to help guide our treatment and our recovery response. Genotypes 1 and 4 historically responded poorly to interferon, whereas genotypes 2 and 3 responded well. Serotyping can be useful when RNA is undetectable, and viral load testing is used to monitor treatment response because patients with high baseline viral loads have a poorer prognosis. And these tools are still relevant when assuming disease burden and treatment planning. Before we shift over to hepatitis E, it's important to kind of wrap up our Hep C prevention strategy because we do not have a vaccine for hepatitis C like we do for hepatitis A and B. The CDC's prevention strategy focuses on two goals: preventing new infections and reducing liver-related complications in those who have already been infected. Our key prevention measures include risk reduction counseling, safe injection practices, infections control in healthcare settings, and screening blood and organ donors. For patients already infected, we identify at-risk individuals, test them, link them to care, and manage liver disease to prevent progression to cirrhosis and hepatocellular carcinoma. And these steps are really important because chronic hepatitis C is often silent for multiple decades.